Kanski lecture series, and this is going to be the chapter 12, and it is uveitis part 1. So basically the uvea is a tissue, vascular tissue of the eye. You know that eye walls has three layers. One is uh, outermost coat, which consists of cornea and sclera, the innermost the middle layer, which is called uvea, and the inner layer, which is called the retina. So in this part we are going to discuss about uveitis, and it is one of the most important topics of the eye, because it is one of the commonly encountered disease. So basically the inflammation of the uvea is called uveitis. So what is the clinical features? Classification. The standardization of a uveitis nomenclature, Sun Working Group Guidance on Uveitis Terminology endorsed by the International Uveitis Study Group, categorizes uveitis anatomically. Anterior, intermediate, posterior, and panuveitis. So basically there is a Sun classification which is also endorsed by the International Uveitis Study Group about the anatomical classification. These are anterior, intermediate, posterior, and panuveitis. The anterior chamber is the primary site of inflammation. The anterior chamber is the primary site of inflammation. Intermediate, primarily vitreous inflammation, include pars planitis, and posterior retina or choroid. Panuveitis, all uveal structures are involved. So basically the anterior is consist of the anterior chamber, and intermediate is basically including the vitreous inflammation, and it also consists of the pars plana, and the posterior side consists of the rest of the choroid. Panuveitis, all uveal structure is involved. So you know that basically the uveitis consists of the iris, then there is a ciliary body, and there is a choroid. So when the iris is involved, basically it is anterior. When the ciliary body is involved, it is intermediate, and when the choroid is involved, it is known as posterior uveitis. An international uveitis study group clinical classification based on etiology is also in use. Infectious, bacterial, viral, fungal, parasitic, others. Non-infectious, with and without a known systemic association. Masquerade, neoplastic, and non-neoplastic. The Sun Working Group guidance includes the following description relating to the timing of inflammatory activity. Onset is sudden or insidious. So basically it can be sudden or it can be gradual. If the duration is limited, less 3 months or less, or persistent. So if the duration is less than 3 months, it is or it can be more than 3 months, it is known as persistent. Clinical course, it can be acute, of sudden onset, and limited duration. So acute is basically when the onset is sudden and it is of the less than 3 month duration. Recurrent is the repeated episode separated by the by untreated inactive period or chronic. Persistent duration with relapse less than 3 months after the discontinuation of the treatment. So basically in persistent duration, the duration is more than 3 months even after the discontinuation of treatment. Remission is defined as inactivity, no visible self, for 3 months or longer. Clinical features. Interior uveitis. So this is an anatomical classification of uveitis. This is interior, intermediate, and posterior. Interior uveitis. Introduction. Interior uveitis is inflammation involving the anterior uveal tract, the iris, and the interior part of the ciliary body, and is the most common form of uveitis. Iritis refers to the inflammation primarily involving the iris, and iridocyclitis to the involvement of both iris and the interior ciliary body. So basically, you know, anterior uveitis consists of the inflammation of iris and anterior ciliary body. So it is further divided into iritis and iridocyclitis. So when only the iris is involved, it is known as iritis, and when the both ciliary body is involved, it is known as iridocyclitis. And in this part, both are usually not distinguished clinically. Acute anterior uveitis is the most common presentation, of which HLA-B27 related and idiopathic forms make up the largest proportion. So basically the most common cause of acute anterior uveitis is idiopathic, or it can be related to the HLA-B27. Etiology in these cases is uncertain but may involve cross reactivity with particular microbial antigen in genetically predisposed individuals. Acute anterior uveitis can be a feature of a wide variety of ocular conditions such as trauma, including surgery, lens-related inflammation, and herpes simplex infection, or can be secondary to inflammation elsewhere in the eye, such as bacterial keratitis and scleritis. Acute anterior uveitis can also be a presenting clinical scenario without accompanying intermediate or posterior uveitis in a range of a systemic condition, including the chronic inflammatory disorders such as sarcoidosis. So basically, the writer is trying to suggest the other causes of uveitis instead of idiopathic. It can be related to other cases like trauma. It can be due to lens related. It can be due to herpes simplex virus infection, secondary to the other inflammation like keratitis, scleritis as well. Then there is a chronic anterior uveitis. Chronic anterior uveitis is less common than acute anterior uveitis. It is more commonly bilateral, and associated systemic disease is more likely. So chronic anterior uveitis is basically uh, persistent uveitis, and it is usually bilateral and associated with systemic disease. Granulomatous inflammatory signs, see below, are often present. Surveys of the systemic association of anterior uveitis vary in their finding. Table 12.1 lists important possibility but is not exhaustive. The prognosis is usually good in most idiopathic and HLA-B27 related AAU, provided management is adequate. Outcomes are more variable in chronic anterior uveitis and in cases where there is underlying ocular or systemic disorders. Table 12.1 Systemic association of anterior uveitis. Idiopathic, no detectable systemic association around 50%. There can be infectious, non-infectious, and masquerade lesion. Varicella zoster. So infectious causes can be due to varicella zoster, usually recurrent, current or past ophthalmic shingles. It can be due to tuberculosis, syphilis, Lyme disease, miscellaneous systemic viral infection. Non-infectious disease can be due to HLA-B27 positivity. Around 20% of the AAU with and without manifestation of HLA-B27 related systemic disease. Non-infectious can be caused by juvenile idiopathic arthritis, sarcoidosis, Behcet disease, tubulointerstitial nephritis, and uveitis syndrome, systemic lupus erythematosus, multiple sclerosis, and drug-induced. Masquerade lesions are neoplastic, lymphoma, and anterior segment melanoma. Non-neoplastic include the juvenile xanthogranuloma. So, what are the symptoms of the clinical features of the acute anterior uveitis? First of all, what are the symptoms? Symptoms in acute anterior uveitis consist of the rapid onset of unilateral pain, visual loss, photophobia, redness, and watery discharge. Sometimes preceded by mild ocular discomfort for a few days, as recurrent disease is common. Especially with the idiopathic and HLA-B27 related types, there will often be a history of previous similar episode. Chronic anterior uveitis may be of insidious or acute onset and can be asymptomatic until the development of complications such as cataract. Visual acuity is variably impaired depending on the severity of inflammation and the presence of complication. It is frequently only mildly reduced in acute anterior uveitis. So basically, the visual acuity is reduced in a case of acute anterior uveitis or impaired. Ciliary injection, very important. So it is very different from conjunctival injection. Basically, in this ciliary injection, there will be around the limbus, there will be the inflammation of the conjunctiva. Ciliary injection or a perilimbal injection, ciliary flush or just injection is circumcorneal conjunctival hyperemia with the violaceous purple hue due to the involvement of the deeper blood vessels and is typically seen in anterior uveitis of acute onset. Ciliary injection is characteristically absent in some forms of the chronic anterior uveitis and occasionally acute anterior uveitis. So we can see figure 12.2a. A is showing us a ciliary injection. There is an inflammation of the conjunctiva around the limbus. Meiosis due to pupillary sphincter spasm predisposes to the formation of the posterior synechies. So you can see figure B is showing meiosis of the pupil. There can be meiosis in a case of a acute anterior uveitis. Next is an anterior chamber cells, very important. Interior chamber cells are a dependable indicator of inflammatory activity. Grading Sun working group is performed by estimating the number of cells in a 1 by 1 mm by 1 mm slit beam field, employing an adequate line intensity and magnification. This must be performed before pupillary dilatation, which can lead to the shedding of pigment cells into the aqueous. Inflammatory cells are commonly also seen in the anterior vitreous. So basically 1 mm into 1 mm beam is used, and along with that you can see the cells in the anterior chamber, and how many cells are there, you count them, and you, according to the Sun working group classification, you place it is 1 plus 2 plus 3 plus how many it is. So this is the group table, and it is a standardization of a Uveitis nomenclature working group guidance. Grading of anterior chamber cells 1 mm into 1 mm slit beam. So basically what you do is, basically, this is cornea, this is iris, and between them is an AC, and you put a light on the cornea about 1 mm and 1 mm on the iris, and between them you can see the cells, and you count them. If it is less than 1 cells are present, then it is 0. If 1 to 5 are present, it is 0.5 plus 0.5 cells. If 6 to 15 are present, it is plus 1. If 16 to 25 are present, it is plus 2. If it is 26 to 50 are present, it is plus 3, and if it is greater than 50, then plus 4 cells are present. Aqueous flare is a haziness of the normally clear fluid in the anterior chamber, reflecting the presence of a protein due to the breakdown of the blood aqueous barrier. So in the cases of the uveitis, the blood aqueous barrier is being broken down and it releases protein, and because of these protein, you can see that the normal AC is usually clear, but in a case of a uveitis, it will have some milkiness appearance. So according to that milkiness or whitishness, you can grade that what is the rate of flare. Based on the work in the children with juvenile idiopathic arthritis associated cow, it is now thought that in most or all patients, the presence of flare indicate active inflammation with a resultant high risk of complication over the longer term. Flare may be graded clinically using a slit lamp to assess the degree of interference with visualization of iris and lens. When available, laser flare photometry gives greater objectivity. So you can see here is a Sun working group scheme of the anterior chamber flare. If there are no flare, you can grade it 0. If there is a faint flare, you can plus 1. In moderate flare, there is iris and lens detail are clear, so you can give it plus 2. In marked, iris and lens detail are hazy, it is plus 3. If it is intense fibrin or plastic aqueous, it is plus 4. Hypopion refers to a whitish purulent exudate composed of a myriad inflammatory cells in the inferior part of the anterior chamber, forming a horizontal level under the influence of the gravity. So basically in a hypopion, basically there is a hypopion, which is basically the inflammatory activity that settle down in the inferior part of the AC, forming a horizontal level until under the influence of gravity. Hypopion is common in HLA-B27 associated and acute anterior uveitis when a high fibrin content makes it immobile and slow to absorb. In a patient with the Behçet disease, the hypopion contain a minimal fibrin, so characteristically shift according to the patient head position. So basically in the case of a usually it contains a high fibrin material, so that is why it does not move. But in the case of a Behçet disease, it has a lower fibrin content, and that is why it moves with the movement. Hypopion. Next is the keratic precipitate. Keratic precipitates are the deposits on the corneal endothelium composed of inflammatory cells such as lymphocyte, plasma cells, and macrophages. So basically, these are the deposits on the endothelium. These are composed of lymphocyte, plasma cells, and macrophages. They are usually concentrated inferiorly, often in a triangular pattern with the apex pointing up, alt triangle, under the influence of gravity and aqueous convection current. So gravity is going down and aqueous current is going up. So basically due to that portion, the KPs are usually in the inferior part of the retina in a triangular fashion. A notable exception is Fuchs uveitis syndrome, in which they are diffusely distributed. Their characteristics indicate the probable type of uveitis, smaller in the non-granulomatous inflammation typical of acute ADA uveitis, and medium to large in classically chronic granulomatous inflammation, in which cell types may include epithelioid and the multinucleated giant cells. So basically, then the KPs are divided into non-granulomatous and the granulomatous. So in a case of a granulomatous KPs inflammation, which is known as granulomatous inflammation, the cells are going to be large and they contain the epithelioid and multinucleated cells. Large greasy apparent granulomatous KPs are said to have a mutton fat appearance. KPs are small to medium and adopt a star shape, stellate, or filament morphology in the Fuchs uveitis syndrome. So, in a case of a Fuchs uveitis syndrome, they are going to be in the multiple star shape, uh, small KPs, very small KPs. So, we can see figure here. It is showing KPs. A is showing histology, showing typical aggregate of inflammatory cells on the corneal endothelium. B is showing highly magnified view of the fresh KP on the inferior uh, in, uh, in the early anterior uveitis. C is showing large mutton fat KPs. D is showing stellate KPs in Fuchs uveitis syndrome. E is showing old pigmented granulomatous KPs, and F is showing the endothelial cellular dusting in early KP formation. KP usually resolve as an acute inflammation subside. Long-standing non-granulomatous KP may become pigmented. Granulomatous KP may become pigmented and or assume a ground glass appearance. Endothelial dusting by numerous individual cells precede the formation of a true KP aggregate. Fibrinous exudate in the AC is a common in severe acute anterior uveitis, as with hypopyon is often seen with HLA-B27 related inflammation. Iris nodule can occur in both granulomatous and both non-granulomatous anterior uveitis. Busaka nodules involve the iris stroma and are a feature of a granulomatous uveitis. Coepi nodules are located on the pupillary margins and may be the site of the posterior synecdoche formation. So we are basically studying the signs of the uveitis. So in a case of an acute anterior uveitis, there can be the nodule formation. So when they are on the iris stroma, they are known as Posaka nodules, and when they are along the pupillary margin, they are known as the Coepi nodules. Yellowish nodule can develop from dilated iris vessels, roseole. In a syphilitic uveitis, iris pearls may be seen in lepromatous chronic anterior uveitis. So basically, pearls are seen in, pearls are for L. So lepromatous chronic anterior uveitis is seen, whereas roseole is seen in the syphilitic uveitis. Iris crystal Russell bodies thought to consist of immunoglobulin depositors are rare finding in some of the chronic uveitis, including Fuchs uveitis syndrome. So we can see figure 12.5. So 12.4 is showing fibrinous exudate, A is showing mild and B is showing severe. 12.5 is showing iris nodule on interior uveitis. A is showing large nodule in sarcoid uveitis. B is showing Busaka nodules and Coepi nodules. So this is a Busaka and this is Coepi. And C is showing Coepi nodules. D is showing iris crystals in chronic anterior. Russell bodies in a chronic anterior syphilitic uveitis. Posterior synecdoche. Posterior synecdoches are inflammatory adhesions between the pupillary margin and anterior lens capsule and may be particularly likely to form at the location of the Coepi nodules. They can develop rapidly, and to prevent their formation, initial prophylaxis with a mediatic agent is routine in all but very mild acute anterior uveitis. Once established, every attempt must be made to break the posterior synecdoche before they become permanent. So basically, in a posterior uveitis, there is an adhesion that form between the iris and the capsule, and basically it is basically a predisposing condition called Coepi nodules that forms this type of adhesions, and you can use that is why we use Mitretics in uveitis to prevent the posterior synecdoche formation, or you can, if there are already established posterior synecdoche, you can just break it with surgery as well. Iris atrophy may offer useful diagnostic clue. Diffuse stromal or atrophy is seen in Fuchs uveitis syndrome, and a patchy or a sectoral atrophy can be seen in herpetic uveitis. So basically, in a case of if there is a diffuse atrophy and there is a sectoral atrophy, so diffuse atrophy is seen in Fuchs uveitis, whereas sectoral atrophy is seen in the herpetic uveitis. It can be due to herpes simplex virus or herpes zoster virus, and inflammation thaw later is said to be more commonly give a sectoral pattern. So zoster will give the sectoral, whereas HSV will give a patchy atrophy. Heterochromia iridis. So there can be the different iris color in case of a uveitis, especially in a case of Fuchs uveitis syndrome, which is also known as Fuchs heterochromia iridis. Refers to a difference in the cover between the iris of the two eyes best seen in daylight. In the context of uveitis, heterochromia characteristically occur in Fuchs uveitis syndrome. Iris neovascularization, rubeosis iridis can occur particularly in chronic inflammation. The process tend to be less than acute than with the primary vascular cause such as central retinal vein occlusion. So basically, sometimes the vascularization can occur. Abnormal iris vessels are commonly seen in Fuchs uveitis syndrome, but they do not cause cynical angle closure. Iris neovascularization may also occur in posterior uveitis, particularly when retinal perfusion is compromised. So basically, when the retina is getting hypoxic, there are the presence of the iris neovascularization to become formed. New iris vessels may be difficult to differentiate from dilated normal vessels, sometimes called pseudorubeosis. Normal vessels course radially in contrast to the irregular distribution of neovascularization. Fluorescent angiography may show leakage from the new vessel, though this can also be seen with the dilated normal vessel, particularly in the presence of active inflammation. Intraocular pressure may be reduced as a result of impairment of aqueous secretion by the ciliary epithelium or elevated due to a variety of mechanisms, including the use of topical steroids. So basically, the intraocular pressure can be high and low in the case of uveitis. So whenever there is a low uveitis, it can be due to there is a ciliary body shutdown and there is a decreased aqueous humor production. And increased IOP is due to basically the inflammatory cells that are obstructing the trabecular meshwork. The trabecular meshwork itself can become inflamed, like in trabeculitis, or it can be due to the steroid that are using in the case of a uveitis. Posterior segment examination should always be performed to detect a masquerading cause of interior uveitis, for example, retinal detachment tumor, primary, intermediate, or posterior segment inflammation, and complication of interior uveitis such as cystoid macular edema. Posterior uveitis. Posterior uveitis, so basically, the posterior uveitis is basically the inflammation of the choroid. So with the choroid, that the most commonly linked with the choroid is the retina. So most commonly, if the inflammation is in the choroid, then retina is going to be affected. Posterior uveitis encompasses the clinical entities of retinitis, choroiditis, and retinal vasculitis. Some lesions may originate primarily in the retina or choroid, but often there is an involvement of both retinochoroiditis and chorioretinitis. Specific condition will be discussed later in the chapter. So what will be the presentation? Presentation vary according to the location of the inflammation, tree focus, and the presence of arthritis. For example, the patient with a peripheral lesion may complain of floaters, whereas patient with the lesion involving the macula will predominantly complain of impaired central vision. So whenever there is going to be lots of cells, the patient may complain of floaters, and if there are macula is involved, there can be decreased vision. So what happened in a case of retinitis? In a case of a retinitis, may be focal, multifocal, geographic, or diffuse. So the lesion can be anywhere. It can be small, it can be multifocal, it can be involving the whole retina, or it can be geographic. Active lesions are characterized by the whitish retinal opacity with the indistinct borders due to the surrounding edema. So basically, retina is giving the whitish lesion, whereas choroid is going to give the yellowish lesion. So whenever there is a whitish lesion with the edema, there is a retinitis. As the lesion involves the resolve, the border become better defined. Choroiditis may be focal, multifocal, geographic, or diffuse. It does not usually induce vitritis. In the absence of concomitant retinal involvement. Active choroiditis is characterized by the round yellow nodule. So choroiditis is having the same appearance, but it is having a round yellow nodule. Vasculitis may occur as a primary condition or as a secondary phenomena adjacent to a focus of retinitis. Both retina arteries, periarteritis, or vein periphlebitis may be affected. So this is the posterior synecdoche. A is showing adhesion in active and acute uveitis. B is showing extensive synecdoche and the pigment on the lens following the severe acute anterior uveitis. C is showing pound down pupil. D is showing dilatation, after dilatation showing pigments on the lens. So retinitis, we're discussing that there can be the venous arterial involvement or venous involvement. Although the venous involvement is more common, active vasculitis is characterized by the yellowish or gray-white patchy perivascular cuffing. So basically along the vessels there will be the cuffing like present, which is going to be yellowish or gray-white. Sometimes associated with hemorrhage, quiescent vasculitis may leave perivascular scarring, which should not be mistaken for the active disease. So when the disease is not active, it is going to leave scarring. 12.7 show extensive iris atrophy following the herpes zoster ophthalmicus predominantly sectoral pattern. 12.8 is showing the signs of posterior uveitis. A is showing retinitis, B is showing choroiditis, and C is showing vasculitis. So in this case vessels are involved, and along that it is a lesions are involved. This is a yellowish nodule and this is a whitish lesion. So that's it for the uveitis part 1. See you in the next lecture.